So how can we reduce clinical reasoning to a tweet? Keeping in mind that a tweet is 140 characters or less. So clinical reasoning is how we problem solve in general practice. It's the thought process behind how we diagnose and manage a patient's presenting complaint. It's a combination of knowledge, analysis and pattern recognition, developed through seeing patients over time. And as Albert Einstein once said, education is not the learning of facts, but the training of the mind to think. Clinical reasoning requires curiosity. Why did my patient present today? Clinical reasoning is a learnt skill, and just like driving a car, it takes time, it takes an instructor, and it takes repetition. So most of you will be familiar with John Murtagh's textbook and have been told that you're required to read it, and I found that many of you actually weren't quite sure why. So in Australian general practice, we use the Murtagh diagnostic strategy for developing clinical reasoning skills. John Murtagh was a GP originally from country Victoria, and he's written many of the texts that we use today. And his diagnostic model has defined how we practice safely in general practice in Australia. So his diagnostic model broken down, what was the probability diagnosis? What's the serious disorders not to be missed? What are the pitfalls? What are the masquerades? And is this patient trying to tell me something or a yellow flag? So after working with the previous remediation group, we came up with a modified Murtagh model, and I found that understanding clinical reasoning was a large part of their exam failure. They told me that they'd read Murtagh, but really didn't understand the importance of it or why they had to read it. So we came up with a few prompts to stick on the wall near the computer screen. So how does it work? So this was a child who had a fever for the last 4 days. They were 18 months old and had developed a rash. The rash started on the body and the neck and started spreading to the arms, the legs and the face. They were a bit cranky and had a little bit of diarrhoea and vomiting. So roseola is the most likely diagnosis. But was there anything serious not to be missed? Yeah, a couple of things come to mind straight away. Measles and meningococcal. Is there anything else that this could be? Yeah, possibly. Hand, foot and mouth or rubella, but knowing that rubella is unlikely in Australia in vaccinated populations. Are there any red flags that I should be concerned about in this child? Is this child dehydrated? Is this child got symptoms which really don't quite fit my diagnosis? So how am I going to safety net myself? So safety net means making sure that you and your patients stay safe. And examples might be to provide some written information about the condition, or to advise the parent on what symptoms would trigger a hospital visit, and bringing the patient back for a review the next day. So how do we practice clinical reasoning? We do it on every patient that we see. Stick the reminder up on your wall and be an investigator and think, why is my patient sitting in front of me here today? There are some really good ways to practice clinical reasoning in your own clinic. If you get the opportunity, observe others in your consultation. This can be done in your clinic or through watching video consultations of those who do this well, and you can do that through YouTube or RVTS, or participating in the workshops. It's an excellent learning tool. So how do you know when you're actually doing clinical reasoning? Seek feedback. Get a colleague, a medical student, to sit in on your consult. Video your own consult and watch it. Send it to your supervisor to review and seek feedback. So feedback is an essential part of growing up as a clinician. Feedback's a gift, and it makes us much better GPs and helps us learn clinical reasoning. So did I do it? Yep. Managed to reduce clinical reasonings to a tweet. Actually, 107 characters to be exact. So thank you for listening, and I look forward to working with you all over the next few months.